Imagine a world where medical data, regardless of its format or complexity, can be autonomously analyzed and transformed into actionable insights. BUDDI AI's solution reads and contextualizes unstructured medical records such as lab reports, claim forms, explanation of benefits, even payer contracts, enabling the automation of previously complex manual tasks across the provider, payer, and pharmaceutical spectrum. Our initial use case of this technology is automation of outpatient medical coding. I am Shelly Fowinkle, the Senior Vice President of Revenue Cycle Management for BUDDI AI. We employ over 400 resources in Chennai, India, and the United States. Our C-suite and go-to-market team is US-based and led by our CEO, Swaminathan, which you meet during the Q&A. The remainder of our team are India-based and led by Venkatesh Prabhu, our Chief Technology Officer, and Sudarshan Sanathapan, our Chief Data Scientist. We have decades of artificial intelligence experience, which we continuously evolve through our partnership with the Indian Institute of Technology Madras AI Lab, in addition to holding multiple AI and ML patents. The problem: medical coding, even with the use of computer-assisted coding, still requires human interaction on every record. The adoption of EHRs permitted providers to document and code simultaneously. However, providers now spend 26% of their time engaging with patients and 74% of their time solving tasks in their EHR, a factor that's leading to physician burnout. Employment of medical coders brings other complexities, such as the training for regulatory updates, coverage during sick or other absences, quality concerns, and slower turnaround times to complete coding. Market opportunity. Referencing a JAMA article, administrative complexity is defined as waste that comes from inefficient or misguided rules in healthcare and represents $265.5 billion and includes $17.6 billion in physician time reporting on quality measures. So what is our solution? BUDDI AI's first market solution is coding AI. The right side of this slide shows our contextual logic taking unstructured data, converting it to structured, and graphing for the purpose of medical coding. This allows our solution to autonomously code procedure, modifier, quality measures, and diagnoses with up to 85% of the total volumes at 95% or better accuracy with zero human interaction. This is due to our hybrid technology approach, which layers 1 million rules on top of the self-learning AI. Some of our key features and benefits include a SaaS cloud-based solution that is agnostic. It could be in your cloud or our cloud. We also engage with multiple EHRs or electronic health record systems and are specialty agnostic. In addition, turnaround times are from real-time to 6 hours. Our business model for coding AI is a pricing solution by transaction. Our initial go-to-market strategy was through white label partnerships with revenue cycle vendors, and we recently begun a direct-to-provider strategy. In addition, in September, we launched our autonomous revenue cycle management billing platform and are currently developing autonomous speech recognition. Traction and milestones. Through our RCM white label partnerships, we currently service over 300 hospitals and code more than 3.4 million charts per month. On average, 85% of this volume is coded autonomously with no human interaction, and our average coding accuracy on this volume is 98.7%. To date, we've coded more than 100 million records with turnaround time from real-time to 6 hours. Our challenges and mitigations. Our challenges include staff perception of automation threatening job safety, for which we mitigate by guiding our client to repurpose the resources into other roles. Another challenge is general perceptions of artificial intelligence, which we mitigate with education, consistent monitoring, and auditing. Also, it's difficult to provide references due to our white label channel. We're mitigating this by marketing direct to provider groups. Key takeaways. We have a proven AI tech stack that can deliver at scale across multiple specialties. We have many compelling application and use cases of our core technology across provider, payer, and pharma ecosystems. And we are seeking partnership to pursue variant use cases of our technology, in addition to participation in our upcoming Series A funding round. If you would like more information, please contact us at connect@BUDDI AI.
Okay. Wonderful. Thank you so much, Shelly. Round of applause for Shelly. Okay, I think we have Shelly on for some questions from the judges.
Hello, this is Megan Brown. Have you all connected with any payers, and how are they responding to this technology? As of today, we have a lot of different rules and regulations in place that will not allow overseas, will not allow AI as it is. And how have you all gone through that?
Sure. Thanks for the opportunity, HitLab. And again, my name is Swaminathan, co-founder, CEO of BUDDI AI. To answer the question, we've actually been helping the providers through RCM channel partners and direct providers as well. Now, for the payer angle, what's transpiring in the industry today is something called as real-time settlement, where there's actually cost on both sides, both the provider side and the payers. And we have engaged now a couple payers, one of which is actually Blue Shield California, where we are working with them on a POC where we can help them actually on real-time settlement, where they're helping their provider network to also reduce the inefficiencies, because there's a double-sided cost involved in this process, and they're lending their adjudication APIs in the process. So there is a convergence in terms of autonomous reimbursement from the provider side, but the payers want to join this effort so that they can reduce the cost on their end, because they have call center cost and all kinds of other reimbursement costs in terms of AR follow-ups and all of that. So the quick answer is yes, we are working with the payers now, slowly but surely. But then the only way we could even get there is to work hard to be able to automate in scale and be able to prove it to the payers that this autonomous technology is real, and we are automating in scale today.
Okay. Thank you, Ram. Do you have a follow-up question from the judges?
Yes, hello there, Felix Lee. So I'm wondering whether you've tried to quantify from your existing customers kind of the scale of potential savings or net savings, I guess, because if you're coding more accurately, probably there will be more payouts as well.
This is a loaded question. I'm going to try to make it as crisp as I can. When it comes to cost, so let's take a step back, right? Medical coding is by and large the crux of the bedrock of how payers reimburse providers. So when it comes to pre-BUDDI, which is like companies like Optum and 3M, they've been doing what is called as computer-assisted coding, which means there's always a human in the loop, 100% of the time. So when you look at this industry, in a given year, medical coding and billing combined, the spend is actually close to $270 billion in 1 year. Now, when you look at that spend, it's predominantly manual labor. Now, where BUDDI comes in is that we come in with an accuracy guarantee in the contract with a volume guarantee as well. So we have a very, very strong principle that if you are an AI company in healthcare, you need to be able to guarantee to the provider both the volume that you're going to automate with what accuracy. Now, Medicare stipulates that you got to be at least 95% accurate, and it allows only 5% error. Now, what BUDDI has done is using very complicated math models, like probably approximately correct algorithms, PAC guarantees, where we do not allow more than 5% error, which means the providers, over a period of auditing, they have actually figured that they can trust BUDDI and send the code straight to the payers for reimbursement, which means we're able to cut down the labor cost for the providers, which means those auditors are the only ones who are there to audit. The bulk of the stuff, either in-house or outsourced, is gone. BUDDI is actually a proof that AI can automate in scale with accuracy and volume guarantee. So that means the cost of labor is savings. Second is we have also proven over a period of time now that more than 60% of the medical necessity and coding related denials are completely knocked off, 60% of them. So within the first 14 months of us going live, which means that we are actually able to reduce those denial costs for the providers. And McKinsey, in one of the great articles in reimbursement, actually points out that for every claim denial a hospital goes through, the rework cost is at the minimum $25, and it goes all the way up for very complicated denials like medical necessity, which means BUDDI is able to save those rework costs for the providers. And not just that, we're able to actually reverse some of these denials upfront. So we're able to predict it and prevent it as well, right? So in terms of savings, just to come to your point, it's probably our largest customer, which unfortunately I can't name them. It's one of the largest insurance companies in the country, so you can know who it is. We essentially save them at the minimum $14 to $15 million in a given year. Just to give you some perspective, in terms of the savings we've already delivered for them. Our 5-year contract is already up for renewal for them, and we're renegotiating that right now. So we've been able to prove that we are able to get the savings by reading unstructured medical records agnostic to specialty. And that's the other thing about us, that we've actually worked very hard in reading unstructured radiology notes, pathology notes, cardiology, E&M, ambulatory surgery, ortho, emergency. So we've gone and been able to prove this across multiple outpatient specialties.
Thank you very much.
Okay, fantastic. All right, do you have any final questions from the judges?
Hi, Glennis Mara here. In terms of the therapeutic coding, what we've seen in the past is that there's quite a bit of overlap, so you can have physical therapy with or without a particular device, and there's gradations. And does your system capture that? Even though there's
Yes, we do.
Yeah, considerable human error in that space.
So when it comes to the problems, could you guys hear me? I'm sorry.
Yeah, we can hear you.
Okay. To answer the question, the technology is such that it's trained from it's an LLM technology. So it's a Gen AI based LLM and MLM, masked language models as well. So we would train with enough amount of history, as little as even 6 months, as much as actually even 3 years, how much you can share. We would actually triangulate the error rates by also bringing in rules as well. Now, one of the reasons why we're very successful in what we do is very early on we realized just deep learning models alone in healthcare is not going to be sufficient, to attain accuracy on a consistent basis. That's one of the theses that we have, that folks like GPT-4 cannot really do what we do unless they bring in tons and tons of rules into the equation as well to make sure they cap the amount of error rate and they can actually guarantee the consistency of accuracy. So what we would do in this use case is exactly the same, that we would understand, we partner up with you, and we would have sufficient amount of history so that we can actually triangulate the error rates, and we will shrink it and make sure we have a consistent outcome.